Okay. Okay. Welcome, everybody. Today is Therapy Thursday. It is the 4th of February, 2021. And my name is Evan Adler. I am a physical therapist and proud host of this series, Therapy Thursday, brought to you by UNC Healthcare and the community community engagement committee. And what we do here as a service to the community at large here is just provide information on popular topics to really help people out, where we would usually be talking to everybody in person. Because of COVID, we've developed this here so we can really reach out to greater masses with some great information and help you out as best we can. Before we get started for today, I want to let you know that we do have a Facebook page that I would encourage you all to join to find out more information about upcoming Therapy Thursdays and other events coming up. And I will put that information in the chat. And also, all of our Therapy Thursday presentations live on our YouTube channel, and I will put that information in the chat as well. So today we have a very specific presentation that it's very great for the times that we're living in right now. Ain't that a kick in the head? Today's presentation is all about headaches and pandemic living. So I am going to turn it over to expert clinician and a good friend of mine, Kyle Cooper, and he will take it from here. We'll leave some time at the end for some questions, but I'll be monitoring the chat during the presentation. So if you do have questions, kind of just drop them in the chat there, and we can either save them to the end, or if they're super urgent, we'll get to them as we can. All right, take it away, Kyle. Well, gotta get that mute. Wait, Kyle. Oh, wait.
Can you hear me?
All right.
Can you hear me now? I think I was still on mute. Yeah, I see a thumbs up. Evan, can you confirm that you can hear me too? Just to make sure. Sweet, yeah, looks like okay. All right, yeah. Thanks for the introduction, Evan. I really appreciate that. Yeah, so welcome to Therapy Thursdays. This is my first one. I'm glad to be here. Thank you all so much for joining. I was trying to brainstorm ideas that I felt like would be relevant to our time, and I've personally been seeing a big increase in like headaches and TMJ or facial pain disorders in my own practice at the ACC, and there seems to be a lot of pandemic-related factors involved in that increase in that patient population coming into the clinic. So I thought, I presented to Evan that we would do a presentation on headaches, and I just want to give a brief overview of headaches, pandemic living, how that's all contributing, give you all some strategies for how you can improve your headaches or prevent headaches from happening during this crazy time, and then also give you like a little bit of insight into what we might do in physical therapy if you were to come see us for head or facial pain. Let's see if I can get this slide moving along here. Okay, so some learning objectives. We're not going to get into the weeds with all the specific subtypes of headaches and the pathophysiology and that type of thing. We're just going to briefly discuss the primary categories of headaches and the top three that we would typically see in an outpatient PT setting, and the top three that most people struggle with. We're also going to learn how COVID has impacted a headache frequency and intensity in our society. So just what researchers and what clinicians are seeing as far as the prevalence of those of that condition and what may be contributing to it. We're going to learn what factors can influence in our daily lives to positively impact the frequency and intensity of headaches. So the things that you have control over, where it may be stress or posture and positions, we'll briefly talk about that. We're going to learn about the basic components of a physical therapy exam, focus on head, neck, and facial pain. So we'll just touch on what your typical PT exam would look like for head and facial pain. And then we're going to learn about what impairments a physical therapist may target to minimize or eliminate your headaches. So what are the things we typically pick up on in our exams when we know we can help a patient with their headaches? And what things are we picking up on that we know we need to refer a patient? And then lastly, we're just going to quickly go through some interventions. I've got some summary slides just showing you what some of our interventions would look like, hands-on techniques and different types of exercises that we may do in the clinic, just to give you a little insight into what happens in the clinic and maybe even some ideas for your own self-care. A little bit about me before we get going. I'm a proud husband and father. I'm married to a PT over at Duke, Darcy. We got 2 girls, Sadie and Ava. COVID appropriate picture there with our mask on this past fall. I got my BS in exercise science at Elon University 2008, and I got my doctorate in physical therapy from UNC 2011. Worked in private practice for a while, and then I came over to the UNC a few years ago, about 5 years ago, and then I became board certified specialist in orthopedics in 2017. I've been practicing about 9 years. And recently I was promoted to clinical supervisor, although it's not that recent anymore. It's about a year and a half now. So I'm a clinical supervisor with UNC Therapy Services. I work with Evan and our team over here. And my primary work location is the Ambulatory Care Center. So I'm just right across the street from the main hospital. So one reason this topic is kind of important to me is I have my own headache journey, and I don't want to get too far into this, but I've always had an interest in headaches and facial pains because, partly because when I was a kid, so when I was around 16 years old and I was playing football, and I was kind of ramping up some activity on the varsity team, I started to develop severe headaches in the back of my head and in my forehead and some dizziness and disequilibrium, and I was bounced around from provider to provider trying to figure out what was going on with that, and found that to be quite frustrating as a young person, and it definitely had an impact on me. Eventually it was pretty clear now that I'm a clinician that I had like multiple concussions that went undiagnosed, and because that wasn't really much of a thing at that time, it wasn't really something we were talking about like we are now in the sports med ortho world. And then eventually I was found to have an Arnold Chiari malformation, which is where your cerebellum kind of pushes out of the base of your skull. It sounds a lot worse than it actually is. It's a fairly large percentage of the population has it, and it's completely asymptomatic. And I've always wondered how much of that was a contributing factor, or how much of it was cervicogenic headaches and some of the other things that we'll touch on today. So my own headache journey, basically of having head pain and facial pain as a kid, and then kind of resolving that after discontinuing some different type of activities in football, and working with a few clinicians has certainly influenced my practice, and it made me passionate about this area, and really wanting to help people get help faster and resolve their pain without drugs and surgery and that type of thing. So yeah, the biggest thing to know about headaches, if you're experiencing it, is you are not alone. It is by far one of the most, if not the actual most prevalent condition in the U.S., resulting in pain and disability. The lifetime prevalence of headaches is 96%. So basically, if you're a human, you're going to have headaches and facial pain at some point in your life. Very similar to back pain, although back pain is a little bit lower than this. So just being alive and living in our world, especially in our modern world with technology and all the stress and demands that we place on our body, a very, very high prevalence of this. I don't know what those 4% of people that don't get headaches are doing, but but it's a very small group of folks, and honestly, I don't know that I've ever met anyone that's never had a headache personally myself. And then if you were to survey just the general population at any given time, you're going to find that about 50 or 60% of the general population has headaches at any given time. So on this call right now, I'm sure a fairly large number of you are having them. I've had a headache recently. Ironically, it was a few days ago while working on this presentation. So it happens. It's a normal experience. It's not always something people seek care for, so it may be underreported in the literature because most people just kind of suffer through it. And it's estimated that about 45 million Americans suffer from persistent headaches. So not only are we have a large population that has a headache, but we've got millions and millions of people that have headaches on a regular basis, daily, every other day, several times per month, enough that they would label it chronic or persistent. It's also a huge financial burden on our society. We've got headaches as one of the major reasons that people have to miss work, they have to miss school, and one of the main reasons that people visit their doctor. So the financial burden that it places on our employers and on our own finances, and on our school system is really astronomical. So one estimate I read is that migraines alone, which is just one of 150 different subcategories of headaches, accounts for $17 billion annually. So just that one subtype is really impacting our society in a major way. And I just want to take a moment and just say, pandemic living is hard. And I think we're all feeling this stress. I found some images here to just kind of represent what I feel like has been going on in my own life with work, working from home occasionally, kids trying to navigate school wearing masks, businesses closed, getting tested for COVID, political unrest in our country and that type of thing. And all of this has contributed to all of our collective stress, anxiety, the wear and tear on our body, the wear and tear on our psyche, and is likely contributing to what we're seeing with this increased incidence of headaches. This pandemic truly is a headache. It's a headache and is creating headaches. So preliminary studies and some of this data, and we'll probably see more of this come out post pandemic, which will hopefully not be too far in the future. And anecdotal reports, even in my own practice, certainly the frequency and intensity of headaches among our patient populations, especially with migraines and tension type headaches, which have a high stress kind of comorbidity, have increased dramatically during the pandemic. So if you survey folks that have persistent migraines, pre-COVID and post-COVID, we're seeing a dramatic increase in what they're reporting as their level of disability. So there's been a clear shift during this time that's really pushing folks migraine, tension type headaches, and even some cervicogenic or more neck pain related headaches in the wrong direction. And we don't have any data to really support any of these things, but clinicians and researchers, and certainly myself, all have kind of theorized that maybe this is related to a number of factors such as stress, which we just mentioned, sleep disturbance. If you're like me, all of the stress associated with pandemic living has certainly created some irregular sleep patterns. Psychosocial stressors, so people have lost their job, they're having to work in different settings, they're having to work in new roles, they may be doing something that they've never done before in a new COVID specific role, especially here at UNC Healthcare. Childcare issues and illness, personal illness, illness of family members. We're also seeing a dramatic reduction in physical activity. Gyms are closed. People are not able to gather socially and do group exercises, which are a huge part of our culture and things that keep people moving. And we know that a lack of physical activity results in more persistent pain and more trouble with all types of pain, including headache. And then we're also seeing an increase in negative coping. So folks are, of course, trying to stress shield and using more alcohol, smoking more, caffeine consumption is up. All the things that we would do to try to kind of balance out our lives have increased. And then also changes in work routines and patterns. I'm sure many of you on this call have had more work from home this past year and probably sitting more, zoned into Zoom calls, endless WebExes and things like that. All of that stress placed on our physiology from sitting for prolonged periods of time and having so much screen time probably has an impact on headache. Like I said, we don't really have data to support it yet, but if it's consistent with what we already know about facial pain and head sensitivity, then it likely is a contributing factor. The other thing we know right now is that people aren't getting care. Pre-COVID, less than half of the people that have headaches seek care. So there's a lack of providers that feel competent in treating headaches, which is one of the reasons I'm passionate about it, because there's just not many people that like to treat it, to be completely honest with you. It's kind of an underserved area of practice. There's a lack of awareness among the general public about there even being options. Most people just assume I have to suffer with this. This is what I have to deal with, and they don't realize that they can seek care. there's a lack of public health initiatives focused on headaches. So you don't really, I mean, I'm sure most of you have probably never seen a specific advertisement or a public health initiative geared solely for headaches, you know, and reducing persistent pain associated with headaches. So there's just a general lack of awareness. And then on top of that, we have COVID. So COVID has made all of that stuff worse. Not only do we have a lack of providers, now we have a lack of access. So we have people that can't get care because, you know, virtual appointments are their only option, or they have no time because they're working and taking care of kids all the time and running around trying to make life work during COVID. There's safety concerns, of course, for being seen in person if someone wants a thorough evaluation, which really needs to be most of the time an in-person evaluation. There's certainly COVID safety concerns associated with that. And then there's a lower priority, I think, in most people's mind of like, oh, well, COVID's really bad. My headache in comparison to like COVID related illness doesn't sound all that bad. So I think people have kind of reorganized some of their health issues, you know, diabetes, cholesterol, high blood pressure, headaches, you know, and said to themselves, maybe I can forego treatment this year while things kind of shake out with COVID. And I would argue that that's probably not a good thing. You know, people living with this as in living with many other comorbidities and health issues is not really a positive thing for folks. So we hopefully we can see people start to seek care appropriately and get more awareness out in the public about there being treatment options for these conditions. So understanding your headache. Again, I don't want to get really in the weeds with this. I just want to briefly touch on it. There are over 150 different types of headaches. It takes a neurologist many, many, many years of subspecialty practice and training to get where they can differentially diagnose all these different subcategories and give people a clear answer to their problems. So we're not going to be able to get into that today. But what I will say is it's helpful to kind of understand the two different types of categories when making decisions about your own health. One is that there's a primary headache, and the primary headache is really what we're going to be talking about and what PTs will treat 99.9% of the time. And that's the problem is your head. So basically a primary headache is your brain activity, the overactivity of the pain sensitive structures in your head, neck, and facial region, including the nerves and blood vessels. Even the muscles and ligaments and tendons around your head and neck are involved in this. And that, so all of that in and around your cranium is considered a primary headache. So it's the reason, primary, it occurs independently, and it's not really dependent on another disease or pathology to drive it. It's independent, and we sort of treat it and investigate it in that way. And then we've got a secondary headache, which is really another huge broad category. And it's typically a secondary headache is there's going to be an underlying medical condition. There's going to be a disease process. There's going to be a trauma to the head or neck, like a concussion, sport-related injury. There's going to be an infection or some other disorder that's driving that. A really common one would be concussion would be great, would be a really good example of that. An infection, so having some, even COVID actually would be a really good example of that. So COVID, one of the symptoms that you get asked about when you get screened for COVID is about head and facial pain, and the inflammation and the disease process associated with COVID can create a headache, but that would be secondary because it's COVID driving the problem, not necessarily your head and face driving the problem or your brain and spinal cord. So those are the two main categories. And within that, we PTs and neurologists, you know, we all try to differentially diagnose and dial it down to what we think is the most specific version of those things that's going on. And most of the time, for folks ending up in PT and even ending up in primary care talking about headaches, they're going to fall into one of these three categories. And there's a bunch of other ones, but these are the three main ones. The ones that PTs can really hit a home run with is cervicogenic headache. So you can see there in the chart, it's a 50-50 split for male and female. It's typically unilateral, so it's on one side of your head. It will side shift occasionally, but not always. It'll be in and around your cranium, your eyeball region, the lateral aspect of your head. It can be chronic, so you can have it all the time. You can have it occasionally. It varies in intensity and duration. It can be moderate to severe. Folks typically describe it as an ache, a non-throbbing type pain, so it's an ache, a soreness, discomfort, typically neck movements exacerbate it, and there's tenderness around the face and head with that. So it's a pretty easy one to diagnose because you can just poke around and have the patient move their head. And if that's you, if you can turn your head left or right or up or down or touch around your head and neck like I'm doing right now and feel tight areas and soreness, it may be that your headache, at least part of your symptoms, fall into this category. And it's a huge percentage of folks that have headaches. It's just straight cervicogenic. It's a peripheral problem, meaning that it's the muscles and tendons and the muscle tension and the heightened sensitivity of those structures in and around your head that's driving the pain. Migraines are super complicated, a bunch of different subcategories of migraine. It's going to be a 75 to 25 split with female versus male, so many more women have migraines than men, at least reported in the literature. Maybe underreported for men, based on the studies that have been done. It is, most of the time it's unilateral, but it will shift sides. It can be in that same frontal region, lateral head, and temple, and even around the eyeball. The frequency is a little bit lower, so 1 to 4 times a month. It'll also be severe, moderate to severe. It can last 4 to 72 hours, so that's a clear differentiating factor for that. If it's over 72 hours, it probably isn't a migraine, although certainly people fall outside of that. The quality of the sensation is more of a pulsing, a throbbing sensation. Neck movement isn't always involved, although I will say there's a lot of coexisting cervicogenic and migraine pain, so those things can kind of come together. And then the thing that most folks know about is nausea, vomiting, the aura, all these other weird neurological changes that happen with migraine that make it a little bit easier to diagnose. If someone's having all those things going on, likely they are experiencing some migraine. It looks like somebody's raising their hand. Evan, was that
Yeah,
you?
that would be me. So I don't know if this is the best place to ask this or not, but there was a question that came in about the value of Botox for headaches and the commercials that are out there. I don't know if you address that later on or what have you.
Yeah, I don't really get into that. I'm trying to focus mostly on PT specific interventions. PTs don't do Botox injections. We do dry needling, which is basically sticking the needle in without any medicine. So Botox would be wet needling. So they put the Botox in your hypertonic muscles. And yeah, I think it makes clinical sense to me that if you have a hypertonic, tight, muscle that's really giving a person a lot of discomfort, and it's overactive, if you were to temporarily paralyze that muscle with some Botox, certainly it would, I think, have a positive impact. And I do think there's some emerging research out there showing that it does have a positive impact on headaches. Although, unfortunately, I think it's short-lived, which I think is where PT and some of the lifestyle interventions that we're going to touch on in just a minute will have a bigger impact, in that you can get this window of time from Botox where your symptoms will be reduced, but then it's figuring out what all the triggers are and the movement patterns and the stressors in your life and some of the other things that may be contributing to that hypertonic or really tight muscle, where I think you're going to eliminate your symptoms, versus having to go in for Botox on a regular basis and having that become part of your lifestyle. And it's expensive and I think burdensome on people to have to do that. So long story short, I think it's a good option, and certainly there's a lot of headache specialists, neurologists out there that really feel strongly about it, and it makes sense to me. But as a biased PT, I would argue that in addition to Botox, we need to address those other impairments, those other problems that you have that would likely be leading you to have more head pain. I hope that answers your question. If not, feel free to unmute yourself and jump in or put it in the chat. So I'm not going to get into the neuroanatomy too much. I just wanted to put this slide up, just to show you the complexity of the nervous system and the musculoskeletal system in the head and neck region. We have neural tissue that comes in and around our face, our jaw, into our cervical spine and our spinal cord region. It all shares ganglions and central points of communication in our central nervous system. And many times that competing demand of communication to and from our spinal cord and our brain can create all of these weird symptoms that you may have experienced. So people with headaches sometimes have dizziness, sometimes they have ringing in their ears, sometimes they have jaw pain and locking, right? All of these structures share neurovascular tissue. So if you irritate one, you can excite all the other ones and create problems in all the other regions as well, right? So this shared neurovascular system can create problems. And if you look on the left-hand side there, you also see the muscles that kind of wrap around all this neural tissue. So in addition to having the shared neural tissue, we've got a lot of muscles that tend to get tight and irritated and hypertonic, and they can squish those nerves, and they can create compression injury that can give us facial pain, headaches, jaw pain, ringing in the ear, that type of thing. So just want to point that out and just show you the complexity there, and kind of how all these neural tissues and muscles and tendons are competing to send your brain and spinal cord the information that lets you experience pain, unfortunately. So, and then I also wanted to bring up some red flags. So I think, this is mostly what PTs are looking at to make sure you need to be in physical therapy and don't need to go back to your doctor. But I would say even on the patient side, for you, if you're experiencing any of these things, anything that you would say is weird, right? Like it's not normal to have your arm just go completely weak. It's not normal to suddenly have intense vomiting that you can't control with a headache. It's not normal to have difficulty swallowing or tingling around your lips, or a chronic cough or voice change that comes along with a headache. It's not normal to have a change in your cognition, to feel like you can't think clearly or you can't say your words in the appropriate way. And then it's also not a normal thing to have a sudden severe onset of a headache. So if you have any of these things on this list, you need to go to your doctor, and sometimes it may be even an indicator that you need to go to the emergency room, right? This isn't a physical therapy issue if you're experiencing some of these red flags, and it's not a take care of yourself at home kind of issue. It's a need to follow up on the weird stuff to make sure that we can rule out all the bad things that the headache could be. And then if it turns out to be a mechanical problem that PT can treat, certainly your primary care doctor or your neurologist or whoever evaluates you can make sure you get to our office. So I think it's important to just give that list a quick look, and just use common sense when you and your family are kind of evaluating your symptoms. So now I wanted to, before we get into PT, I just wanted to touch briefly on what you can do at home to address some of these problems, right? So we know that there's a number of factors in the literature that we have control over, and that we as patients and people experiencing pain, things that we can do to treat our symptoms at home without even accessing care, and experiment with and see if we can manipulate and modify our symptoms at home. So the biggest one is sleep. Sleep comes up over and over and over and over in the literature. Sleep is huge. It's known that a lack of sleep provokes headaches, and that getting restful sleep improves headaches. It's that clear cut. And that's not just headaches, that's chronic pain in general. If you have persistent pain anywhere in your body, if you can sleep more soundly, the chances of you getting better increase dramatically, right? So sleep disorders, there's a high comorbidity of sleep disorders with headaches, and we know that if you can nail that down and work with your doctor, work with your PT and counselors and other people to try to get that under control, it's going to have a huge impact on your head pain. Just a few little points, and sometimes we coach patients on these things. Practice good sleep hygiene. So we want to establish a winding down routine. If you don't have a way to wind yourself down in the evening, read, relax, journal, do whatever it is that makes you feel all warm and cozy and ready to go to bed. Try to get that routine down. If you have an abnormal sleep and wake cycle, if you're going to bed late, waking up early, vice versa, and you're inconsistent, and I was just joking with Evan that that's a common issue right now. We both have toddlers, so we're constantly waking up at weird times, and it's almost impossible to do that, and I realize that's probably the case for a lot of you too. But regardless, trying to get closer and closer to that goal of regular sleep-wake cycles, having a dark room, keeping your room cool at night. We want it at 68 degrees is what most folks agree is a good temperature to just let your body kind of regulate itself at nighttime. And then, of course, no distractions. I do find it's interesting, a lot of patients have their kids in their bed, their pets in their bed, they have their phone right up underneath their pillow, checking it during the night. So using a little bit of common sense and just knowing you don't need distractions at nighttime. And then if you have trouble with any of these things and you can't figure it out, you certainly need to seek some expert guidance. There's a ton of counselors and neurologists and PTs even that kind of focus on sleep. And I'm sure if you do some research, you could find a handful of folks that could help you try to establish some better patterns. And then similar to sleep, exercise for persistent pain for almost all types, including headaches, is the best medicine. If we can get people moving at the recommended levels, which now, and it's recently been updated, is 150 minutes a week of moderate intensity or 75 minutes of vigorous and a couple of days of strengthening, we know that folks feel better. Their head feels better, their back feels better, everything feels better, right? And so we've got to get moving again, especially in this pandemic world. It's really easy, and I've been feeling it myself. I'm a gym rat, so I'm out of the gym, and it's really hard for me to get back in my routine and start exercising again. And we have to figure out ways to get that back in our lives so that we can manage our head pain, but then also manage our overall health. It's just so important for everything. The only subcategory of headaches that sometimes doesn't respond to vigorous exercise is migraines. And I do think that one is important. If you have migraines that increase with exercise, that's something to address with your doctor or your PT and discuss strategies for figuring out how to get your exercise level at the appropriate amount for your overall health. But just know that if you are struggling with migraines, that may be a limiting factor for you and a barrier to getting this piece into your pandemic headache plan. And then I just want to say all types of exercise work. So specific strengthening, necks, arms, trunk. If you want to do that, that's great. If you want to do generalized strengthening, that's also great. Aerobic exercise, recreational activities, all of these things are great. The important point is that you get moving. And if you get your body moving and producing all the good neurochemistry that helps us regulate pain, you're going to feel way better. And it's just, and honestly, I don't care how people want to move, just as long as they get moving and get the work in consistently. It seems to have a positive impact on their pain experience. Self-massage. Unfortunately, not a lot of evidence to support this, but I will say anecdotally and with patients, doing some massage and working on the tight muscles in and around your back and your neck is an easy thing to do at home. It's fun, feels good. And I say if it feels good and it has a 10% chance of helping you eliminate some of your pain, why not? So get a foam roller, you can get a ball. PTs are happy to show you how to do this when you come in for your appointments, and we can educate you on how to do it properly. There's also honestly a lot of great resources on YouTube and a lot of other exercise platforms that you can consult, and it's really hard to screw it up. So I think it's a great thing to test out on your own at home. And then we got managing stress. Right now, things are so super stressful with COVID. So we got to stay connected to friends and family, meet outside, maximize your technology to have Zoom dates with folks and meetings with your family and friends, set boundaries at work and home. This is so hard right now because we're in this COVID productivity push, as we're all being asked to work from home and do different things. And I think it's important to have those boundaries for work and home, and create space at home for work and leisure. So if you're working from home a lot, make sure you've got separate places where you can relax and where you can work. Deep breathing helps. It just helps calm your nervous system down. It helps teach your brain and spinal cord, hey, I'm not under stress right now. You don't have to be producing pain and making me uncomfortable. And then leisure time activities, making sure you're checking in with your hobbies, your music, your crafts, your recreation, whatever gives you meaning. And then address your spiritual needs. So if you normally attend church or you do other things, having that as part of your life certainly is going to be beneficial for managing your stress. And for a lot of folks, the spiritual and sort of religious, philosophical aspect of our lives has kind of deteriorated with COVID, unfortunately. And then practice mindfulness and meditation. So PTs can help coach you on this. There's certainly a lot of counselors can help with that too, and psychologists and that type of thing. But if you don't have a daily practice of mindfulness, checking in with your emotional and physical state, highly encourage you to do that. It'll help you self-regulate your nervous system and teach your brain that it doesn't need to be under so much stress all the time. Focus on your breath, focal point, a mantra. You can experiment with different positions, lying down, sitting up, standing, whatever works for you, sitting at your computer, sitting on your couch. It doesn't really matter. Just play with it and try to figure out ways of calming your nervous system down during the day will certainly have a positive impact on your pain. And if you're uncomfortable getting started with it, there's a bunch of free resources online certainly consult a professional or someone that has a strong practice, and they'll be able to help you with that. I just put a link there, and you'll have the presentation if you wanted to see some virtual options. And then some mobile apps for meditation and self-care. So there's a lot of things out there, and there's more and more coming out every day. Calm, Headspace, Strides for habit tracking, MyFitnessPal, gratitude journals. I mean, there's really, especially right now with COVID, so many of these things coming out that are free or cheap, or you just pay kind of as you access the resources. So I would highly recommend you try to check out some of those things. I personally have used Calm, and I find that to be a good one, and have a lot of great meditation guides and that type of thing. So I'd strongly recommend you check it out. And then posture and ergonomics, evaluating your work situation at the office, at home, wherever you tend to do your work. Check in with your body throughout the day. Is your body telling you that you're in a bad position? If it is, try to switch, change it up. Move to the couch, move to the bed, move to your recliner, move to your chair. Have a high-low table like what this guy here on the right has, where you can elevate your workspace and lower it back down during the day to give you some breaks from sitting. And then I like to, and I don't know who I stole this from, but I've always said that the best posture position is your next posture position. And I think that's so true. There's no ideal posture. We've preached that a lot in PT, but really the reality is there is no ideal posture and position. It's any posture and position for too long of a period of time is detrimental to your muscle bellies. We are creatures that are meant to move continuously all day. And if we stay in a sedentary position for too long period of time, our body, our physiology will feel that, including our head and neck, especially because of what's required from computers to really focus. And then last thing, we talked about this a little bit earlier, but reduce negative coping. So excessive screen time, Netflix binges, phone scrolling binges, alcohol, nicotine, excessive caffeine intakes are certainly a problem in my life right now with trying to manage all the complexity of life with COVID. But just being aware of these things and knowing that, that this is a component. We know that excessive caffeine intake definitely makes migraines worse and some other types of headaches worse. So if that's a issue for you right now, certainly thinking about that, and I've been thinking about it in my own life, is an important thing to do. And then lastly, for this care category, or self-care category, is seeking care, right? So we just talked about folks don't feel comfortable seeking care for headaches. Oh, I'm just going to suffer through it. This is just, part of my life and that type of thing. You don't have to be in pain. A lot of these things can be resolved. If it can't be resolved through movement and exercise and stretching and hands-on work, certainly a neurologist can help you identify, some solutions, whether it be Botox, which was just mentioned earlier, or medication. I personally, one of the reasons I'm a PT is I don't want people to go down that route. But some people need medication. Some people need surgery. It's just a reality of certain conditions, and you're not going to know until you seek out care and reduce the burden of headaches in your own life. So I would just encourage you to use the resources available, schedule that virtual appointment, and get some care for your head discomfort. So how can physical therapy help? So we're going to dive in a little bit into the exam components and what PTs are doing to help folks with head and facial and neck pain. So if you come into a physical therapy visit for an evaluation, you can expect the first thing the PT is going to do is sit you down in the chair and start asking you questions about the onset, the location, the intensity, the duration of your pain, your history, your medical, surgical, social, medications, your activity profile, all of these things. And then lastly, what are your goals? What's going to change in 5 or 6 weeks that we can say, hey, we've hit a home run in therapy. You're sleeping better, you're having less pain at work, that type of thing. So we're going to nail all that down in our subjective. Then we're going to do an objective exam. We're going to look at your posture. We're going to look at your range of motion, flexibility. We're going to test all your muscle strength. We're going to look at your reflexes. We're going to touch around your head and neck to see what's tight and tender. And then we're going to look for a retest response. So we're going to treat you a little bit, and then we're going to get you up and have you turn your head and move and say, oh, is that better or worse? And hopefully you say you feel better, and then we know we're on to something. We know we've identified something we can treat. Typical impairments we're going to see: limited range of motion, tenderness in the head, neck, and face. We're going to find trigger points in there. Sometimes we press and pain refers into the forehead, pain refers into the lateral shoulder. We're going to find hypomobility of the joints. So we're going to touch those joints in your neck, and they're going to feel stiff, and you're going to say, ow. Incoordination of the muscles, weakness of the muscles, and poor endurance of some of the muscles that help support your head and neck. Abnormal postures, we're going to observe that maybe your posture is not ideal, and there may be some things we need to work on there. And then we're going to test to make sure that mechanical stress increases or decreases your symptom, to make sure that we're dealing with that primary headache or cervicogenic headache that we know we can treat in physical therapy and don't need to refer you back out. And then I see I'm running out of time here, so I'm going to quickly go through our exercises here. So the interventions that we'll typically use, mobility exercises. So if we identify someone stiff or tight, we're going to mobilize them. We're going to get them stretching their head in the rotation, extension, back to the side, whatever directions we find that restriction. We're going to do some specific strength and coordination exercises. If we find that you have a control deficit or problems recruiting the appropriate muscles in our exam, we're going to teach you how to recruit those muscles, how to move in a more mechanically friendly way so that your neck and your brain and your spinal cord and all the nerves in your head and face aren't under so much stress all the time. And then we're probably going to do some generalized strengthening. We want to get all your muscles in your upper body and torso especially stronger. We know that stronger people have less pain, so we want to get you strong. After we figure out how to recruit those muscles, we're going to teach you how to get strong and how to be strong for the rest of your life. We're going to try to help you understand where aerobic exercise fits into your life. What's your starting point? Where do we begin getting you moving again? What impact does that have on your symptoms? And then help you identify a plan for increasing that over time. We're going to mobilize your joints. We're going to get in there, and if we find a stiff joint, if we find a tight area of muscle or ligamentous tissue, we're going to use our hands to get in there and mobilize that tight area and loosen it up. And hopefully when we loosen that muscle, that ligament, that tendon up a little bit with our hands, you get up off the table and you say, wow, I feel 50% better. I feel 100% better. And you get 10 or 20 more degrees of range of motion. That's the ideal response. And we're going to use our hands to do some mobilization or manipulation. A lot of people think of manipulation as more of the chiropractor's world, but we do some of that in PT as needed. And it has been shown in the literature to be a very effective intervention for cervicogenic headaches. So if we can crack the neck and get people 10 or 20 more degrees of range of motion, they generally walk out of their sessions feeling way better. And I feel strongly that if that's the case, we need to use that intervention in PT, not just in chiro and osteopathic medicine. Dry needling. And I think this is a video here. Maybe it'll pop up. Yeah, dry needling. So we got, some of you may have done this before. If you've got a hypertonic, tight muscle with a trigger point, we can use a needle to go in there and basically hit the reset button on that muscle belly. There's something about that, and we're still trying to study it in PT and in medicine. There's something about the act of that needle going into that trigger point that makes that muscle tighten and then release, and then that gives you a window of time where you can move and have more freedom of movement that allows you to do the exercises and things that will really give you kind of the long-term benefits of physical therapy. So this is just an example of someone doing that. I've had it done many times. It looks worse than it is. It's actually a very benign. Yeah, and I see there in the chat someone's asking about, yes, it's basically, it's an acupuncture needle. The difference is that physical therapists do it based off trigger points and referral patterns, versus if you see an acupuncturist, they're trained more in Eastern medicine and methodology, and so they probably will needle you along meridians based on the theory that they're going to correct your energy flow and your chi and all. It kind of depends on the provider, but it's a different philosophy of practice. But the needles themselves are acupuncture needles. It's very, very similar. It's just the thought process behind it is different, and how we're using it is a little different. All right, and then we're gonna get in there and work those muscles with our hands. We're gonna massage. We're gonna manipulate that tissue and try to get those tight muscles to be softer, more pliable, so that you don't have so much stiffness in your neck and shoulder driving some of this pain in your head and face area. So we get in there, we do massage, we strum, we stroke, we push, we pull. We have all different techniques that we use to kind of mobilize that tissue. We use tools sometimes. We use these metal tools, instruments. Sometimes we do cupping and some other things, basically just trying to find different ways of loosening up those restrictions in the muscles. Sometimes people have scar tissue, and we can mobilize and release those adhesions in their fascia and muscle and give them some more range of motion. So we use tools for that. And then we teach people how to breathe, how to meditate. We teach them how to downregulate their nervous system so that they can live a more stress-free life, learn how breathing and stress interact with their pain experience. And we do this in a variety of positions. Here's some examples of some exercise software we use, where you can see how we're teaching folks to do that and use their hands to kind of understand how their breathing mechanism works. Patient education. An often undervalued part of what we do is educating folks. We get you in, we teach you about ergonomics. How should you set up your workstation? What's going to be best for your body type and your type of work? We talk about pain. The research is showing if we talk about pain neuroscience and you understand the physiology of your pain experience, you're more likely to pursue the appropriate level of care. You're more likely to feel like you have control over your symptoms. So we want to educate you about that. We're going to do lifestyle modifications. We're going to ask you to try to monitor your sleep. We're going to ask you to create a pain journal. We're going to ask you to challenge yourself to maybe make a few changes that will have an impact on your symptoms with your lifestyle. We'll give you community resources. We'll sometimes help refer you or recommend you go see another provider. If we think you need to see a neurologist, we may say, hey, go see our headache team at UNC, or hey, I've noticed that you have a lot of stress in your life. Would you be willing to go see someone in our counseling department and talk to them about how you're feeling and see if we can get some of this emotional stress out? So we may make recommendations and educate you on the benefit of that from time to time. And then lastly, we're gonna give you a plan to help prevent future recurrence and to continue all the gains you've made in therapy. So if you had mobility exercises and coordination exercises, strength training, cardiovascular exercises that we've worked on in PT, we don't want you to leave until you've made that lifestyle change, until you're walking out the door feeling confident that you can do those things yourself. So we're going to create a detailed plan for you, give that to you, and have you leave feeling like you can be successful and not have recurrence of your head pain again in the future. And then I put a couple of resources here for you. I think Evan posted these presentations, so you can check that out on the web. Lots of great information out there. Lots of really bad information too, so I would recommend use .gov, .org, sites that are reputable. Headaches and back pain are money-making industries for a lot of charlatans and quacks, so you want to make sure that you're reading the right stuff. This is my contact information, so I'm happy to help you with your headaches. My team over at the ACC and our whole therapy services team, we have a bunch of people that really like to treat head and facial pain. Would love to help you figure these things out. So feel free to reach out to my office there. You can email me, you can MyChart message me, whatever you want to do to get in contact with me. And then I just got some references here. So these are just kind of some of the things I pulled together to put this kind of patient-focused presentation together for you. So, and that's it. Thank you so much. I know I went over a little bit, and I really appreciate your time. Is there any questions that I missed popping up in the chat or anything I can help folks with?
There were no specific questions about the presentation. There was just one last question there about, do we see children? And I would just answer that by we typically see adults in our clinic, but we do see kind of like adolescents, middle school, high school age. Any younger than that, they'd probably be a little more appropriate for our pediatric departments. But yeah, so Kyle, thank you so much. This information was really, really fantastic, and it's a lot of heavy stuff to get through. And we've kind of run over on time for today. I will have this posted up to our YouTube channel by the end of the day today. So I would invite you to please go over to YouTube. I put the address in the chat there, and you'll get notified when it gets put up. But all the information from today will be on there. And actually, Kyle, if you wouldn't mind just going back a slide so people can see your contact information. Yeah, perfect. Thank you. So you can take note of his information there. If you have specific questions for Kyle, you can email him directly. If you have questions for me for a Therapy Thursday, or if you have ideas about something you'd like to see us do, you can email me directly at evan.adler@unchealth.unc.edu. And our next session will be in 2 weeks on the 18th, and the topic will be piriformis syndrome. What a pain in the butt, quite literally. So we will see you all again in a couple of weeks, the 18th at 12:30, same link. Sign up on our Facebook event to be reminded about the whole thing. Kyle, you have some fans there waving hello.
Hey.
All right. Thank you, everybody. Great to have you all here today, and we'll see you in a couple of weeks. Thanks, Kyle.
All right. Thank you. Have a good one. Thanks, everybody.